So welcome everybody. I'm Colin Geddes. I'm an adult nephrologist in Glasgow in the UK, and I'm delighted to have been invited to moderate this session, which I think is going to be very interesting. We have our speaker, Max Liebau from Köln in Germany, and he's going to talk about PKD throughout life, recessive PKD in adults and dominant PKD in children. And we've got an expert panel, Emily Cornec-Legal from Brest in France, Anna Teixeira from Porto, Olivia Boyer from Paris, and Peter Czarnecki from the Brigham Women's Hospital in the States. As Max gives his talk, which will be for about the next 25 minutes or so, there'll be an opportunity at the end for questions. I'll keep an eye out on the Zoom group chat for some interesting questions coming through that I may put to Max or the panel. And then afterwards, we will hopefully have a stimulating discussion. So if I can hand over to Max, thank you.
Thank you, Colin. And thank you very much for the kind introduction. So PKD throughout life. But with a focus on ADPKD in children and AR in adults. I can't move my slides now, I'm sorry. There we are. So these are my disclosures for Zucker and Pfizer. So as you all know, the two major forms of polycystic kidney disease are ARPKD, autosomal recessive polycystic kidney disease, and ADPKD, autosomal dominant polycystic kidney disease. ARPKD is characterized by these ubiquitous microcysts that can be found throughout the kidney, and that result in this enlargement of kidneys, usually early in life. These are usually microcysts. Some macrocysts can be seen later on. Whereas ADPKD is characterized by these macrocysts and fibrosis, as shown here on the left-hand side in the pathology sample, the ultrasound, or the MRI. The main genes are PKHD1 for ARPKD and PKD1, PKD2 for ADPKD. For autosomal recessive polycystic kidney disease, Carsten Bergmann's group recently could identify variations in DZIP1L as an additional cause. And then for ADPKD, variants in GANAP and DNAGIP11 have been described. Typically, as it is very typical, the recessive form is much more rare than the dominant form and presents very early in life, usually with an incidence of 1 in 20,000 for ARPKD and about 1 in 500 to 1,000 in ADPKD. The main clinical manifestations are obviously the kidney involvement. There is massive hypertension in ARPKD, usually early in life, hyponatremia, pulmonary hyperplasia, and then there's obligatory liver involvement with congenital hepatic fibrosis and portal hypertension in ARPKD, whereas in ADPKD you have more cystic liver disease. For families, it is important to think about the risk for their own children, which is very low in ARPKD as a recessive disorder, and 50% in ADPKD. For us as clinicians, and especially as pediatricians, it may be helpful to look at the kidneys of the parents. With a recessive disorder, obviously there are no alterations, and in ADPKD, usually one of the parents is affected. For the prognosis, ARPKD is still a very severe diagnosis. There is still substantial neonatal mortality due to the pulmonary hypoplasia. And we and others see that about 50% of the patients go into kidney failure in the first 2 decades. For ADPKD, the median age of kidney failure is 58 years for PKD1 and 79 for PKD2. And there is a small group of patients that shows very early onset ADPKD that may mimic ARPKD clinically. So the traditional view is that ARPKD is a disease that exclusively affects children, and actually I still very frequently hear that these kids are going to die anyway. And the traditional view is also that ADPKD is a disease that is only relevant for adults, and that you should not even talk about it to children. So let's start with ARPKD and a classical ARPKD history. This is a situation that I guess many pediatric nephrologists will know, where we're getting called by our colleagues from Obs and Gynae, and they see a woman in the 25th week with this prenatal ultrasound, these large hyperechogenic kidneys. And there's no family history in the parents. There was an elderly sibling that was affected and actually passed away very early in life, and there are two healthy siblings. And obviously this picture are highly suspicious for ARPKD. So when we are called by our colleagues, the question always comes up, what can we tell the parents? The parents want to know, how is this going to develop? What will the life of this kid, what is it going to be like? What is the renal function going to be like? What about the long-term prognosis? And obviously, what about survival of these kids? So, and for ARPKD, as for many rare diseases, there's the issue that actually we just don't know. So we didn't have the data, or we don't still have the data to answer all these questions. And so we, there's a lot of variability, but there are no good answers for these parents. So there are these recommendations that we set up some years ago, where experts met, and we wrote down what we considered best, but still it's on the level of expert recommendations, and there is still even intrafamiliar variability, so no good way to predict disease causes. Treatment in ARPKD currently is symptomatic, and this is partly due to the fact that there is no established primary endpoint for clinical trials in this rare and variable disorder. So therefore, some years ago, we said, okay, we need to step back before thinking about therapy. We need to go back and describe this disease much more in detail than we previously have done. And we want to establish a deeply phenotyped cohort with evaluation of long-term causes and current treatment approaches. So what are people currently doing? And is there any way to identify clinical or biochemical risk settings that would help us counsel these families and potentially identify a primary endpoint for clinical trials? This idea was supported by the German Pediatric Nephrology Association, the ESCAPE Network in Europe, and the German PKD Foundation. And there are close collaborations with initiatives in the USA with Lisa Gay Woodford, and in the UK with Larissa Karatuk. And this was purely funded by public funding. So supported by the University Hospital of Cologne, by the PKD Foundation, and then later on by the German Federal Ministry for Education and Research. So what do we do in ARPKD? We collect a basic data set that includes things like family history, clinical presentation at the first visit, things like that. And then we follow these patients about once a year with clinical questions, radiology markers, did the kid undergo transplantation, etc. What are the blood values, and so on and so forth. And so we follow them prospectively, but we also have the chance to enter retrospective data. At the same time, we ask for the genetic information to look for potential genotype-phenotype correlations, and we started storage of biomaterial. Where are we right now with ARPKD? More than 100 centers, mainly from Europe and mainly from pediatric nephrology, have registered. These centers come from about 30 countries. And it is, again, part of the European reference networks, etc. We have more than 600 patients included in ARPKD by now, more than 620 as of yesterday, with almost 3,000 independent visits. And I guess an important thing is that we have more than 200 patients now with 5 visits and almost 100 patients with 10 independent visits. So that, for the first time, gives us the chance to really follow these patients longitudinally and look how they develop throughout childhood, adolescence, and young adulthood. The cohort currently is mainly pediatric, mostly because most of the centers are from pediatric nephrology, covering all the different age ranges throughout childhood and adolescence. But now you see there's also a number of patients that makes it into adulthood. And these are patients I want to talk about today. Partly. So what do we tell the parents about the renal survival? This is the data from the registry when we had almost 600 patients included, looking at renal survival that was defined as start of renal replacement therapy. And actually we come out with about 50% renal survival by the age of 20. There are these patients that go into kidney failure very, very early, and these are obviously the ones that we all have in mind when we talk about ARPKD. But there is quite a substantial number of patients, that, 50% that makes it to the age of 20 without kidney failure. And there's like a continuous progression throughout childhood and adolescence. Are there any risk factors for early dialysis dependency that we could identify? Yes, there are. This is a table, and I don't want to go through all the details, but it's one of the works we did a couple of years ago where we compared children with dialysis in the first year of life to children that did not require dialysis in the first year of life. And we looked at all the prenatal, perinatal, and postnatal information, trying to identify risk patterns that would be easily available and would help us to counsel these patients. And what we found is that there were a number of things that were significantly different, both in the univariate analysis as also in the multivariate analysis that I'm not going to show you. In the end, we could establish a model that helped us to identify high-risk patients. And these are the ones that had oligo or anhydramnios detected by ultrasound, enlarged kidneys, and renal cysts antenatally. And you could see that in the model, the probability of dialysis in the first year of life was about 10-fold higher than if you just had enlarged kidneys or just had renal cysts. So this may, for pediatric nephrologists, not be very surprising, but it's the first scientific evidence to define a high-risk group with easily detectable antenatal ultrasound markers. And it may also help to define a high-risk group for clinical trials. So what's the course on dialysis in these kids? I frequently hear that PD, which is the type of dialysis that we consider as preferable in these young children, would not work good in ARPKD patients. So we therefore teamed up with the IPPN registry of Franz Schäfer, which is a global network on, in this case, peritoneal dialysis data. And we identified almost 80 ARPKD patients that were then matched for age and time on dialysis to patients with congenital nephrotic syndrome or CACUT. so congenital anomalies of the kidney or the urinary tract, to other important causes for very early onset kidney failure. And actually, if you just look at the technique survivors, so you know, the way PD works in these kids, there is absolutely no difference between ARPKD, CACUD, or CNS, suggesting that actually PD works equally good in young children as in CACUD or CNS. What else can we tell the doctors? Can we as doctors tell the parents about the long-term prognosis? Here we looked at a sub-cohort of the registry, and we identified more than 40 patients that made it into adulthood, and you know, started by just describing their clinical courses. So each of these is a single patient, and what you see is the red ones are the time with CKD, yellow is peritoneal dialysis, then we have all these transplantations marked here. And what you see is that a lot of patients undergo transplant in late adolescence. You know, up here, what you also see that the clinical course is still very, very variable. When we looked a bit more in detail at this cohort, the median age was 21 years, almost male and equal, female were equal. They had grown more or less well, and surprisingly back then only 40%, so that was a couple of years ago when we looked at it, 40% were in renal replacement therapy. And there were even patients with proven PKHD1 variants and a clinical phenotype of ARPKD that were still in CKD1 when looking at the estimated GFR. Importantly, liver disease seems to become more and more important throughout life, and we found that by ultrasound, almost 60% had signs of either liver changes or splenomegaly. Many patients also had thrombocytopenia, which is taken as a sign for portal hypertension. So it seems that liver disease after childhood is getting more and more important, but we will need much more data on this. This is just a very first description of the clinical presentations. So to summarize this first part, over the past years, we've set up this registry study that has gathered observational data to characterize the clinical course of patients and to identify risk patterns for ARPKD patients. ARPKD patients nowadays can make it into adulthood, and actually we've seen some patients with less pronounced phenotypes that first presented in adulthood. So ARPKD should also be considered as a rare but possible differential diagnosis for cystic kidneys, especially in young adults. So coming to ADPKD, obviously the disease that you as adult nephrologists are very, very familiar with. We all know that classic ADPKD is a slowly developing disease where structural changes develop over the decades, and the eGFR is considered to remain stable for a very long time. And once the structural changes are very pronounced, then GFR declines. So we are looking, obviously, as pediatric nephrologists at this group of patients. For adults, there are the well-established risk scores, the ProPKD and the Mayo score, but they are not established for children and adolescents. So ProPKD considers, for example, urologic symptoms before the age of 35, and the Mayo data start with the age of 16, 17, so they cannot be applied to children and young adults. So that's the situation that I guess many of you will be also familiar with, and that we as pediatric nephrology see plenty of times how to deal with the kids of ADPKD patients. What's the right time point to look for ADPKD or to start treatment in kids at risk, and how should we counsel these families? And for this, we need to weigh the potential benefits of early intervention against the potential burden of early diagnosis. And this obviously has very specific aspects in different countries. We're talking about insurance, etc. But this is something that you need to weigh against each other. So I've brought two patients of ours as examples. Would you treat them or would you not treat them? One's 13 years old, the other is 17 years old. Both have, you know, for their age, blood pressure that is on the high side. Actually, for this 13-year-old, this is too high. Both have slightly reduced EGFR, which may also be to the ACE inhibition that this patient is already receiving. So for us, was important to see that also in childhood, total kidney volume is already associated with high blood pressure, or the other way around. Higher blood pressures are associated with higher total kidney volumes already in late childhood and adolescence. So here we have a group that has a high blood pressure. Here we have a group that has normal blood pressure, all of them ADPKD patients, and this is work by the Denver group that already shows this association of higher renal volume in late adolescence with high blood pressure. So we're seeing a spectrum of ADPKD diseases. We have the classic adult onset or late adult onset. We have the most severe ARPKD likes in this very early onset, and we have these ones with the childhood onset. And we need to identify the patients that would benefit from early diagnosis and intervention. So therefore, we've teamed up within the German NeoCyst consortium that deals with cystic kidney diseases that present early in life, with a number of people, geneticists, adult and pediatric nephrologists, also patient representatives, etc., to set up this consensus statement on the diagnosis and management of ADPKD in children and young people. Very briefly, just some recommendations that we've set up. We believe that all patients of at-risk minors should be counseled about the inheritance of ADPKD and the potential benefits and harms of diagnostic screening. We feel that for asymptomatic minors at risk of ADPKD, the repeated screening for treatable but usually asymptomatic disease manifestation, which is hypertension or microalbuminuria, should be followed up. And this can be done without diagnostic testing by ultrasound or genetic testing, and can be equally valid in clinical care. The decision whether or not to do diagnostic screening by ultrasound or genetic should be shared between the parents. The healthcare professionals and minors should be involved whenever possible. Two more important recommendations. 24-hour blood pressure measurement is the preferred method for defining hypertension in children aged 5 years and older. And for treatment of hypertensive children with ADPKD, we're not super ambitious, but we suggest a target blood pressure below the 75th percentile or below 125/72 millimeters Hg. We also feel that, again, we would need much more data. Therefore, on the basis of ARPKD, we've set up another registry study, ADPKD. This was in very, very close collaboration with Jalila Makali, who's a driving force for this project. Again, we feel we need more longitudinal data on ADPKD in childhood. Currently, we have more than 600 patients included with 79 centers that registered. And this is now part of a global initiative where we have the same questionnaire that was started in Europe, but now fully harmonized with initiatives in the US, in all the different continents, to have a global network for pediatric ADPKD research. Within Germany, there's a close collaboration of us as pediatric nephrologists with our adult nephrology colleagues here in Cologne. So again, we harmonize the data to make sure that our data can be transferred to the adult nephrology registry that they've set up, where they follow more than 700 patients by now. So to summarize, ARPKD still classically is a disease of childhood. ADPKD typically becomes clinically symptomatic in adults, but we believe that there is an overlapping spectrum of diseases, and this can partly also be explained by overlapping genetics. It is therefore important to consider ARPKD as a differential diagnosis in adults and to be aware of the specific issues of ADPKD in childhood. And we and others have set up registry studies like ARPKD, ADPKD, or ADHPKD by our adult nephrology colleagues that may help to characterize the clinical causes of patients as a basis for a better understanding and for observational-based risk stratification. And with that, I want to thank all the people who do the work. Catherine does a great job for the ARPKD registry. There are very important collaborations with Lisa, Jalila, Roman, and Franz, or the funding agency. And finally, for the people in Europe, I would quickly like to show this slide. Everyone who's interested in cilia and cilia-related research, we're happy to invite you to Cologne in October this year, if Corona has gone by then. And I'd be happy to take your questions. Thank you.
Thank you very much, Max. That was very clear, and thanks very much for sticking to time, and that leaves us plenty of time for discussion. It's clear that there are a lot of unanswered questions in this field, and the work that you're doing will certainly help reach some of those answers. I'm keen to ask the panelists for some of their thoughts. You've already raised some important questions regarding screening, and I think probably regarding treatment. And maybe I can start by asking you, Anna, if you have any thoughts about what Max has said, if there are any controversies there.
Thank you. Thank you, Max, for your excellent talk. It was really comprehensive and very, very nice. And sometimes we also have some thoughts on what patients and parents, mainly parents, they ask when we have a probable diagnosis of ARPKD. And do you know in your registry if there are any genetic diagnosis mutations that are related to more severe prognosis? So something that we can say to parents. Of course, we cannot predict pulmonary function. So the first 24 to 48 hours of life, but can we say something to them if they have a prenatal genetic diagnosis?
Right. There's very limited data. What we can say is that patients with biallelic truncating variants have a more severe disease, and it seems to be the case that this is both true for kidney and liver disease. This is unpublished data from our registry. However, we do see that some of these patients now survive. It was previously thought that patients with two truncating mutations would not be able to survive the first month. This apparently is not true for modern medicine anymore. Some of these kids will pass away, but some may well survive. They will be severely affected, but you know that's the way it is. Personally, we've taken care of a kid that had a conserved kidney function until the age of almost 3 years, then underwent combined liver and kidney function, and has a very good quality of life. So this is always the example that I present. For more defined genotype-phenotype correlations, this is something that we're working on very hard, and we will see what the next couple of years will show.
So I'm keen to put some of the questions that are coming through from the general audience to the panelists. Before I do though, Peter, have you got anything you'd like to add about genetic testing?
Well, not at the moment, but I think all my thoughts go a little bit in the direction of the genetic complexity of ARPKD. Obviously, I see things a little bit more through the prism of an adult nephrologist, and in our classical teaching, ARPKD is such a rare condition that we see the peak of the incidence in the pediatric population, and rarely ever does an ARPKD patient, let's call it, graduate into adult nephrology territory. But I think if we look at it from a different angle, namely unknown cystic or fibrotic kidney disease in adults, the patient with undiagnosed advanced CKD at an early age with no other environmental or comorbid risk factors and with no family history. There's a lot of ARPKD or a lot of recessive disease, a lot of nephronothesis, maybe at the level of compound heterozygosity of certain variants of unknown significance that we will then have to call. And the more genetic testing and genomic diagnosis becomes a routine in the way we perform personalized medicine now and in the next decades, the more we will find adult ARPKD that we didn't even know as a syndrome. So I think we should better be prepared to interpret genomic data in that direction, that this disease is probably much more frequent than we know. And I think all these questions, does it tell us about the biology and treatments or so? That's just a totally different level of complexity. But I think this is a highly interesting topic that will affect all of us who are doing adult nephrology with the genetic angle. And there's much more under the surface that we will learn about soon.
Thanks. So some really interesting questions coming through from the general audience, and I'll put some of them to the panelists now. So one of them is, in children who are at risk of ADPKD, when would you recommend, what age, starting to check their blood pressure? I don't know, Olivia, would you like to tackle that one?
You're muted, Olivia.
So sure, thank you very much. What we usually do is each year we test the urinary proteinuria and blood pressure. And most of the time, if the parents are not stressed out, we do not do the genetic testing or the ultrasound until the child is old enough to decide by himself. But we perform each year a clinical follow-up with blood pressure and urinary dipstick. Is that what you do, Max, also? Or?
Yes, I agree. And then we try to get the 24-hour blood pressure measurement once at the age of 5 or 6, depending on what the child will tolerate. If that is completely normal, we will give it a couple of years or 3 years without rechecking the 24-hour blood pressure measurement. If something comes out of it, obviously, it may require treatment, etc.
Okay, and one coming through about measuring total kidney volume in children, would you do it? And at what age would you start? Maybe Emily, would you like to take that one? Remember to unmute your microphone.
Yes, yes, sure. Thank you, and thank you, Max, for the beautiful talk. I think that I usually do first measurement of TKV when I first see the patients in the adult clinic around 18 years old or 20 years old. But I think it's important to repeat the MRI a few years later, because as you've seen on the slides Max shown, at the beginning patients are pretty close one to each other. If you categorize them by your imaging classification, the 8 adjusted total kidney volume at a given age, well, they are not very spread. They have very similar total kidney volume, and it will become, the classification will become more obvious after a few years. So I usually do a first TKV around 18, 20 years old, but I will repeat it after, because it will be easier to have a better idea of the prognosis. Now, also to combine this information with the genetic information is, to my opinion, important.
Thank you. Are any of the panelists doing a total kidney volume in adults or young people who are younger than that?
No, not
Max?
really.
No.
No, I mean, we have these, we would consider it mainly, but also, you know, for scientific reasons, for adolescents in which we find pronounced ultrasound finding. You know, for children and adolescents, ultrasound is the way to start looking at the kidneys. Usually they're not that large, so usually they can easily be measured by ultrasound. If there's something that raises our suspicion, we might consider MRI, but not on a standard basis.
Yeah. So I suppose that then brings us on to the next question that a few people are raising, which is the use of tolvaptan in children. Has anybody any experience of it? Does anybody think there's a place for it?
Should I say something?
Yeah, thanks, Max.
So there is actually a clinical trial going on for tolvaptan in mainly adolescents. Mainly from the age of 12 to 18, with 2 groups, 12 to 15 and 12 to 14 and 15 to 17. The inclusion is finished, and we're now following up on these patients, and we will see what comes out of it. I mean, as you can imagine, tolvaptan for this group of patients in this time of their life may be difficult to tolerate, and this is also something that you know, we're now following up with this clinical trial. For very young children, you need to consider that they also undergo a lot of, for example, viral infections, gastroenteritis, etc. So there are lots of conditions where they may lose plenty of fluids, and they have less of a buffer than all of us adults. So I'd be very careful with the young age for ADPKD. Blood pressure control is something that we are all very familiar with in pediatric nephrology, and that's something that we should try to apply.
Any of the other pediatric nephrologists using tolvaptan in children?
It's not registered in children in France, so usually if the patient wants to have them, I refer them to adult clinics to start them on. For the moment, I have proposed this treatment to most of my adolescent patients, and after discussing with the adult nephrologists, they didn't start the treatment because of the side effects and tolerance and so on. So I have no follow-up data on this treatment in children. If
I may, one one problem you may have by introducing the treatment very early is that in CKD1 patients, the aquaretic effects are much more stronger. And sometimes we are a bit reluctant to start too early in young adults because they will have really severe polyuria, and they might not be willing to restart or resume the treatment a second time if they had a first bad experience with it. It seems to be a little bit better tolerated when the DEGFR is around, drops just below 90 ml per minute than before. I don't know if we have any preliminary data on the dropout rate in the teenage adolescent trial. Max?
Max?
Muted still.
I'm sorry. I think no data that will be public.
Can I ask a few people have been asking questions about what do you advise children about fluid intake if they have either of these conditions, and do you use urine osmolality to guide your advice?
So in the recommendations, we state that they should try to avoid feeling thirst, so they should drink as much to avoid this. We, on a daily clinical basis, we don't usually use urine osmolality, in our outpatient department for these young kids. Yeah. I don't know how the others do it.
Yeah. Sorry. Yeah. Sorry, any of the other panelists do anything different?
No, not different. We usually say patients, they should intake the regular fluid, they should have a regular fluid intake, and also be aware of viral infection, febrile infection, diarrhea, but also usually only during acute infection we monitorize the urine osmolality, so we can have some objective point to point out how is urine density, and to tell them that they should drink more. Usually we do that.
Yeah. So another question that's come through, which is, what is the optimal antihypertensive drug to use in children? Now, if that was asked in adults, we would have a 4-hour discussion. So I suspect it might be the same in children, but has anybody got any advice for the questioner?
We usually use ACE inhibitors if well tolerated, with the usual recommendation to stop when there are GI symptoms and so on.
I agree.
Do you worry about pregnancy in a young woman or young girl being started on an ACE inhibitor, that they might be left on it and become pregnant?
Yeah, that's something that we try to address frequently and very early, which is always kind of embarrassing for the young girls when we start to talk about it. But we try to address it very openly and from early onset. Yeah.
Peter, any thoughts? What do you advise for young adults about fluid intake and how you monitor that?
No, sorry, you mentioned for a minute ago that among adult nephrologists you would end up in a 4-hour-long discussion about what the perfect antihypertensive may be. I don't know. My perception is a little bit different. I think I can grab 10 of my specialized PKD colleagues together, and I think amongst us, I think an ACE inhibitor or an angiotensin receptor blocker is not very controversial. I think that's something that I would get a good majority of PKD nephrologists to agree on. Fluid intake, I mean, we encourage it. We encourage liberal fluid intake as much as people tolerate, but I think you're walking a fine balance about what is feasible, what is desirable, what is disruptive with somebody's life and functioning, and particularly if we have an ADPKD clinic where people come early because they have a family history-based diagnosis and they have the disease, but the disease is long under the radar. Do you want to make them a patient, you know, and being like every day under the Damocles sword of necessary treatments and the ideas of their future morbidity. So I think it's you have to choose an individualized approach, and we are supportive and we are encouraging, but I will not send the cops after every single, you know, patient to guard their fluid intake and their daily lifestyle habits. I think many people have enough awareness from seeing prior generations or their siblings or their cousins that they know what ADPKD is about, and it's based on that awareness and on the mutual trust that you establish.
Yeah.
If I may, just on the same point, I think it's also important to keep in mind that to decrease urine osmolality, not only fluid intakes are important, but also to limit the salt intake, and also maybe so to keep the same recommendation than in the general population. I don't know about in your countries, but in my area, for example, we tend to have a high sodium intake, so try to be around 5 grams per day is important, and also once only protein, animal proteins only once a day should be encouraged. So I think we tend to remember about recommendation about increasing water intake to decrease urine osmolality, but keeping in mind sodium intake and protein intake is as important. Don't know if
yeah. Okay, well,
so.
I think that's been a very useful session. I think it's always nice when we tackle an interface between adult and pediatric nephrology and get to hear the opinions of the nephrologists that we as an adult nephrologist, to hear the opinions of pediatric nephrologists. And it's a really interesting evolving field that we're going to hear a lot more about because of advances in genetics and probably also therapeutics. So I'd just like to wind up by thanking Max very much for an excellent presentation, and thanking all of our panelists for giving up their time to share their expertise. Thank you very much, and look forward to seeing everybody at the next one. It's great to have a form of CPD that doesn't involve having to travel and risk getting cancelled, and I think this is possibly the future of sharing knowledge. Yeah, thank you very much to everyone. Goodbye.